Now in this video we are going to discuss the various thrombotic disorders. Now the thrombotic disorders can affect the arterial tree, they can affect the venous system, they can also affect in some patients only the capillaries, the blood clots in the capillaries, and causes problems there. In general, the diagnosis can be made by clinical features, the rise in D dimers, and appropriate imaging studies. So we can find out, is there any obstruction? Now, obstruction can present in two different ways. Superficial vessels, which are clinically accessible, deeper vessels, which are not clinically accessible. The superficial vessels which are clinically accessible can be the arteries. The patient can present with limb ischemia, patient can present with a stroke, patient can present with blindness. And then the veins, patient may present the deep venous thrombosis in lower limbs, with the deep venous thrombosis in the upper limbs, with superior vena cava obstruction, or patient may present with a venous stroke, like that is dural venous sinuses obstruction presenting as stroke or neurological deficit, and then again a venous obstruction of the retinal vein can produce blindness. And then we can see in the capillaries it can be digital infarcts or digital gangrene, and there can be superficial skin ulcers because of the occlusion of the capillaries. And then we can have problem in the deeper vessels. Predominantly they present with organ dysfunction. For example, if there is an arterial occlusion, it may present with acute coronary syndrome. It may present with the resistant hypertension when there is obstruction to the renal artery, and they may present with intestinal obstruction if the blood supply to the intestine is obstructed. And then venous side, patient can have Budd-Chiari syndrome, patient can have portal hypertension because of the clot in the portal vein, or patient can have venous intestinal obstruction because of the venous obstruction. Patient can have features of intestinal obstruction. And then capillaries, patient may present with brain dysfunction when there is diffuse capillaritis of the brain, that is CNS vasculitis, can present with CNS dysfunction. Patient can present with renal dysfunction if the glomerular capillaries are involved, or if the lung capillaries are involved, patient may present with hypoxia. So these can be varied presentations of obstruction caused by the clotting in the vascular system. Now basically thrombosis is caused by three factors which are called virtuous triad, that is evidence of stasis. The evidence of stasis can be seen in heart, for example, if the LA is dilated or the LV is not functional. So patient may have atrial fibrillation, or patient may have heart failure with a big heart and apex displaced downward. There is stasis of blood, and that can clot and later can embolize as well. Immobilization of a limb or of the patient as a whole can result in bed rest. If the patient is bedridden for a very long time, obesity, hyperviscosity, for example, if there is dehydration, the patient has very high cell count, such as in leukemias like CML, polycythemia vera, or essential thrombocythemia. Patient has a very high protein content, for example, in multiple myeloma. Patient may be predisposed to thrombosis. Similarly, if there is a second component is endothelial dysfunction. If the endothelium is not working well, it can make things clot inside. For example, if there is vascular ischemia, if there is atherosclerosis with endothelial dysfunction, major surgery, trauma, vasculitis, venous or catheters or even arterial catheters can cause this. Some of the drugs may be responsible, and radiotherapy that can cause endothelial dysfunction. And then hypercoagulable state is a third part of the virtuous triad, that blood is very prone to develop coagulation. That can be seen in if there is a deficiency of antithrombin 3, protein C, protein S, there is factor V latent, there is prothrombin gene mutation or dysfibrinogenemia, malignancy, even occult malignancy can cause it, and you can have pregnancy, postpartum period, oral contraceptive pills, and hormone replacement therapy. They all increase the chances of coagulation. Antiphospholipid syndrome, homocystinemia, smoking, and inflammation, they can all predispose to coagulation and producing the hypercoagulable state. So if these are present, the patient tends to develop this coagulation in the circulatory system. Now, how to diagnose thrombosis is we can go for CBC, which can tell us about polycythemia, CML, or similar states with high contents of cellular components in the blood. Then ESR and CRP tell us about the inflammation. D dimers, when there is a thrombosis, this breaks down and produces D dimers which are high. You can check fibrinogen, PT, APT. Particularly APTT may be prolonged in patients who've got antiphospholipid syndrome. And you see both PT and APTT can be abnormal in DIC. The platelets can be low, so that produces a thrombosis because of the Consumption of the clotting factors can be seen on investigation, and D-dimers say they help in finding out that the clotting is going on. Then homocysteine level, antithrombin 3 level, protein C or S, factor 5 latent. Then we can go for anticardiolipin antibodies, lupus anticoagulant, anti-beta 2 glycoprotein 1 for the antiphospholipid syndrome. Complement levels, if the patient has vasculitis which is consuming complements, for example, the vasculitis associated with SLE may be consuming complements. So complement mediated damage to the endothelium may occur, especially in capillaries. And then the anti-neutrophil cytoplasmic antibodies, if they're positive, these are seen in patients who do not have complement mediated injury to the endothelium. And then NMTS, which may be seen in thrombotic thrombocytopenic purpura. And then workup for nephrotic syndrome, that is proteinuria and hypoproteinemia. PNH is also a disease which can cause thrombosis. Then workup for myeloproliferative neoplasm, that includes even JAK2 mutation or bone marrow assessment in some cases. Then workup for lymphoma or occult malignancies. Doppler, CT or MRI that can define the region and the blood vessels which are affected by the thrombotic process. They may be required in some cases, for example, as in dural venous thrombosis, MRI may be useful, and for a DVT, a Doppler ultrasound of the lower limbs may be good enough to document what is going on inside those vessels. And then you may require some organ specific test in individual cases. For example, if a patient has pulmonary embolism because of the DVT, you may require CT, pulmonary angiogram, or conventional angiogram. So these are dependent upon the area which is involved in the disease process. For example, if there is SVC obstruction being caused by large lymph nodes, so then you go for the assessment of those lymph nodes. So these are tests which depend upon the individual case scenario and decide according to the clinical circumstances which dictate which test should be done. Then how to treat. Compression stocking, in particularly in the lower limbs, smoking cessation helps, weight control, lifestyle changes. You may use anticoagulants in acute cases, or sometimes in the beginning of the pregnancy we use heparins. Then we can use warfarin and factor 10A inhibitors. So in valvular diseases which produce thrombosis, we use warfarin. Otherwise, 10A inhibitors are pretty good drugs. And then patients who present with strokes or with myocardial infarction, thrombolytics are a very good option. They can also be used in pulmonary embolism and the limb ischemia as well to salvage the limb. Then thrombectomy can be used in some patients, particularly in the pulmonary circuit and central nervous system. And then patients who got recurrent pulmonary embolism, inferior vena cava filters can also be placed. So these can be different treatment policies in patients who present with thrombotic disorders.